Good evening, everybody. I'm Dr. Bimal Kudavidanage, consultant anesthetist and intensivist at National Hospital of Sri Lanka, Colombo, and the head of the Faculty of Critical Care Medicine of the College of Anesthesiologists and Intensivists of Sri Lanka. I warmly welcome you all participants and the resource persons to this webinar. Behalf of the College of Anesthesiologists and Intensivists of Sri Lanka. Please keep your mics muted throughout the session except for the resource persons. I'm happy to welcome you to our latest webinar on COVID-19 webinar series on physiotherapy's role in COVID-19. This webinar is another step to in series of webinars organized by the Faculty of Critical Care Medicine to update our healthcare providers who are managing COVID patients in Sri Lanka. With the current third wave of COVID-19 in Sri Lanka, we are facing a crisis with an unprecedented number of patients overflowing hospitals with increasing demand of oxygen. It is important to minimize the duration of ICU stay and the need for admission for ICU by proper management of their pneumonia in these patients with a multidisciplinary team. The physiotherapist is a very important member of this team who can contribute to achieve these goals. Therefore, we decided to dedicate this webinar to update our physiotherapists and our clinicians in regards to physiotherapy's role in managing COVID-19 patients. I would like to warmly welcome Professor David McWilliam, consultant physiotherapist, and Ms. Samantha Cook, highly specialized physiotherapist from United Kingdom, who have kindly agreed to be our resource persons for this webinar. I invite you to send your questions through your chat box, mentioning the resource person's name as well, so that we can forward it to the particular resource person at the end of the two lectures. Let me introduce our first speaker, Professor David McWilliam. David is a consultant physiotherapist and associate professor at the University Hospital Coventry and Warwickshire and the Coventry University Partnership Center for the Health Excellence. He is the chair of the Physiotherapy Working Group for European Society of Intensive Care Medicine. David was a member of a guideline development committee for NICE guidelines on critical illness rehabilitation and subsequently quality standard on critical illness rehabilitation. He has extensive experience on research into both early and post-ICU rehabilitation, with more than 50 publications and a regular presentations both nationally and international audience. Let me hand over to Professor David for his talk on acute management of physiotherapy management of patients with COVID. Over to you, David.
Thank you very much. So just making sure I pass test one, which is not to be muted. And then the second is to actually share my screen.
Yeah, we can hear you well and waiting to see your screens. Yeah, we can see your screen as well.
Perfect. And hopefully the slides will be moving. So thanks, Memo. It's a real pleasure to be here and talking to you all today about the physiotherapy role within critical care, and particularly the acute respiratory management. And what I've been asked to cover is proning and then acute physiotherapy. To give you some understanding of my background with COVID-19, so our hospital, originally working in Birmingham and then in Coventry, we've treated now in the region of about 500 ventilated critical care patients with COVID-19. And at the peak of our waves, we had at any one time over 100 patients ventilated within the hospital. So we've seen a lot of these people now. There's still a lot that we're learning, but this is certainly some of my experiences, some of the things I've learned along the way that hopefully will be useful for you all as you move into, sadly, another wave. So I understand there's a mix of professions. There's some physiotherapists, some anaesthetists, and some people from in and out of the ICU. So what I'm going to do to start with is just do a very quick recap on ventilation perfusion, the specific impact then of ARDS, before moving on to proning, specific complications, and then specific ICU physiotherapy management with that critically unstable population. So from a ventilation point of view, we're going to start with the humble slinky. And for those of you that don't know, a slinky is a child's toy that looks very much like a spring and will actually walk downstairs. But anyway, it's useful for this reason, that if you hold a slinky from the top, what actually happens is, because of the entire weight of the slinky acting on the upper regions, it will stretch open. Whereas down at the bottom, when you've not got the weight acting anymore, it's closed. So you get this abnormal or non-uniform distribution of expansion of the links. And this is very similar to what happens with the lung. So when somebody's standing in an upright position, you have the entire weight of the lung acting on these upper portions, which stretch open the alveoli and mean the upper portions of the lung are already a little bit open. Whereas down at the bottom, everything's a little bit squashed together. And what this means is when somebody comes to breathe spontaneously, as air is drawn in, well, in the areas at the top that are already almost fully open, there's very little change and very little additional air entry that takes place. Whereas those dependent regions that are squashed together, you get the biggest amount of air drawn in, and the majority of ventilation will occur at the bottom of the lung in those squash dependent regions. So ventilation increases down the lung from the non-dependent apical to the dependent basal regions. So we'll stick with that and hold that in our mind as we move forwards. Now, from a perfusion point of view, we know pulmonary vascular resistance is very low. Blood that's leaving the right side of the heart has only got to go through the lungs and then back into the left. It's not like the left going all the way around the body. And we have a real vast array of pulmonary capillaries. There's lots of branches covering almost the entire surface of the lung tissue. So actually pressure is low, but because it's a fluid, because there's low pressure, its distribution is hugely impacted by gravity. So as we would probably expect with blood flow, it's going to be affected by gravity. So if someone's in an upright position, it's going to go to those basal regions. If somebody lies on their back, it's going to go to posterior regions. If somebody's standing on their head, blood's going to rush to the head and the upper regions of the lung. So similarly to ventilation, perfusion increases the further down we go in the lung. And this is really useful because for a maximal ventilation perfusion match, we need air and fluid to be in the same place at the same time. So in the normal spontaneously breathing individual, both perfusion and ventilation increase from the apices down to the bases, and it doesn't matter how we turn in space, because that's directly impacted by gravity, they're always in the same place. So we get an optimal VQ match for a spontaneously breathing person in a healthy lung. Now, the problem comes when we put somebody on a ventilator. And even if we put a healthy individual onto a ventilator, this starts to cause problems. The reason being, we consider the analogy before, somebody's sitting up, their lungs at the top are stretched and already partially open. Those at the bottom are squished together. Well, if we're trying to inflate a balloon, for example, if you've got a balloon that's already partially open, it's going to be easier to keep inflating that balloon than it is to be inflating one that's completely flat. So when we start forcing in positive pressure into the lungs, actually what's going to happen is that ventilation is going to be directed into these already open apical regions and away from those dependent regions where we really need it to go. And this causes problems because as ventilation is moved into the upper regions, perfusion is still going to be directly impacted by gravity down at the bottom. And actually, as we start to put more and more positive pressure into the apices, if anything, this is going to divert more blood flow down into the bases of the lung. So just by putting a patient onto a ventilator without considering any pathology, anything else that's going on, certainly without even thinking about COVID-19, we've got a ventilation perfusion mismatch. And this is something we need to start to think about and start to manage. And this is going to, again, be important as we move on to proning. So we've got our VQ, we've got our ventilation perfusion. We know that's already going to be disordered in a mechanically ventilated patient. So what about ARDS? Now, if we're going to talk about ARDS, we need to understand the basics around lung anatomy. And the lung is a highly efficient organ for gas exchange, as we'd expect. So we have an alveoli with a single cell thickness for its wall. We have a very small interstitial space, and then we have a vast capillary bed, as we mentioned before, with just a single cell again. So that oxygen that comes through has got to go through one cell, a small interstitial space, another cell, and then it's straight into the blood. We also have these type 2 cells secreting surfactant. That's helping to provide some lubrication and some stability to that alveolar wall. And we have, importantly, alveolar macrophages. And these are there to really act as sentries. They're waiting for any foreign substances, any foreign targets, anything that comes in, and they will then trigger a localized immune response to fight that infection. Now, what happens within ARDS is something triggers that macrophage, and that starts a cascade of quite a significant immune response. The macrophage itself starts attacking the alveolar wall. It also brings in lots of protein-rich inflammatory fluid that widens the interstitial space. Clotting factors come in which can start to block off. So as well as damaging the capillary walls, they can start to block these capillaries. And you can now see, as you've also lost the factant and stability, any oxygen that's coming into this alveoli has to get through all of this edematous fluid, through that thickened alveolar wall, through the interstitial fluid. And that's even if there's a blood cell waiting or an intact capillary for it to get across into the lung for gas exchange. So you start to understand why gas exchange becomes so difficult, particularly with those patients with severe ARDS. But this gets even more difficult and even more complicated with our ventilated patients. Because it's a fluid that's coming in, and we've already talked about the impact of gravity on fluids with blood flow. Well, actually, it's very similar to this inflammatory fluid. So the best way to think about the lungs now is like a wet sponge. So if you dip a sponge into a bucket, pick it up, what you would have is completely saturated with water at the bottom of the sponge. The middle area will have a combination of some water and some air. And the top, as all the water's run out, is relatively aerated. And this is what we call baby lung, because this is normal or relatively normal lung tissue without any fluid. But as we put somebody onto a ventilator, we're actually trying to ventilate 3 different lungs in the same person. The other thing is, because it's not this uniform, so it's not the upper region of the lung or the upper lobe, the middle lobe, the lower lobe. This will be happening in every segment, every alveoli, every section of the lung. So you get this really heterogeneous lung tissue that we're then trying to ventilate. We consider a normal CT scan, for example. So this is a normal healthy chest, got the heart in the middle. We've got a nice mixture of air and capillaries and blood flow. No fluid around, good expansion, good gas exchange. When we consider an ARDS type lung, this is what we actually see. So we remember the sponge analogy. You've got the areas at the bottom as this person's lying on their back, which are now fully saturated with this edematous rich, protein rich fluid. You've got the middle regions of the lung, which now have a combination of some air entry, potentially recruitable lung, but actually also very damaged lung tissue. And this person, for example, has a little bit of healthy lung tissue just at the top, which is probably now being overinflated by the pressures that we're using on the ventilator. Alongside, as we look at the chest, a very large heart, which is working very hard. So we've got anybody that we put onto a ventilator has an immediate VQ mismatch. We then have this quite significant disorder to the lung tissue itself in terms of gas exchange, which means we've got a very difficult person to a very difficult lung to ventilate. And prone has been, I think, in and out of vogue, certainly in the UK over the last 20 years. European Society of Intensive Care Medicine has suggested that this should be a real mainline treatment for those patients. And I think this whole process for me has been kick-started quite significantly with the onset of COVID. I've certainly seen more prone patients in the last 12 months than I had in my entire 20 years of career before that time point. So the indications are those people with severe ARDS with poor gas exchange despite high levels of ventilatory support. So you've probably seen this already. Those patients admitted with COVID-19 with increasing oxygen requirements, increasing ventilatory requirements, despite with very little impact on oxygenation, things still getting worse. But suggested factors for severe ARDS, for PF ratio of less than 150, people needing more than 60% of oxygen, and those needing high plateau pressures and high peak requirements. Now, why does it work? Well, when we consider the anatomy of the lung again, so this is a lateral view of the chest, what we actually see is there's a much bigger posterior surface area of the lung tissue than anteriorly. So by putting somebody onto the front, you start to utilize this posterior surface. And also because it's a bigger posterior surface, it has a better and more rich blood supply. So actually we start to try and improve the ventilation and perfusion. We lie somebody on their front, we use that analogy to start to stretch open the posterior alveoli, And because there's a better blood supply, we've got more area to get ventilation in. We've hopefully got a better surface for that gas exchange with perfusion as well. Now, the other thing that happens, so I'm not sure if you're getting just my slides or my face in the way, so I apologize. But we've got the original CT scan here that I showed you before with the saturated areas at the bottom, the kind of combined saturation and a bit of air, bit of fluid in the middle, and then the relatively healthy one at the top. But this big heart that's sitting in, taking up that area, it sits on the left base, it compresses that area, it restricts lung expansion. By flipping somebody over onto their front, the heart comes away, it rests on the sternum, that then frees up the left base and all of that posterior section of the lung. And you can see the change straight away in this picture, that you're now starting to get a much bigger area. As all the fluid rushes to the front of the chest, you get much better air entry posteriorly. And also proning has been helped to show that it's a good position for draining respiratory secretions as well, which we're going to come on to in a little while. Ideally, and I think this is where a really important factor with proning, when you have those patients who are deteriorating, is actually that it needs to be initiated early. So I think sometimes in the past, proning's been used as a bit of a rescue therapy. We've tried everything. We've got somebody to maximal ventilatory pressures. We don't really know where to go, and then they're proned. Now that person is probably going to have quite a poor outcome. So the recommendation is, if you have somebody on this course that meets that criteria before, you prone them early within the first 48 hours of onset of mechanical ventilation. You prone them regularly. You prone them for a minimum of 18 hours. It should be used in combination with lung protective ventilation as a mainstay. And as I said, it's recommended for at least 16 to 18 hours. But often, because it's not a natural position, it means our patients need to be deeply sedated and quite often paralyzed. And we certainly saw in our first and second waves, 90% of our patients needed paralysis to be able to manage their ventilation. And that was for at least the first week of admission. So we're talking very sick people, very difficult to ventilate and very difficult to manage. In terms of preparation, I'm just going to go over the procedure. This is the procedure that we use. This is a guideline developed by the Intensive Care Society in the UK. There are various different techniques. I'm just going to show the one that I've been using in my trust. You need to make sure you've got an adequate number of staff, and that's a minimum of 5. We tend to try and work with 7 if we can, but that's one person at the head end trying to maintain the head and the airway, and then 2 or 3 either side. You need to ensure the airway is secure and that the difficult airway trolley is available. Obviously, as you're moving somebody with a lot of attachments, quite a high pressure situation, there's always going to be the risk of accidental extubation. You want to be ready to manage that. Hopefully it's a very rare event, but if it does happen, you want to make sure that trolley is available. We pre-oxygenate people, we put them on 100% for a good couple of minutes before we start. Sorry, I'm seeing lines being drawn on my screen, I'm not sure why, but we'll go with them. You make sure you know where every line is, make sure they're secured, make sure there's enough length. A lot of this proning procedure is about planning and making sure you have somebody that's managing all of those lines, all of those attachments, disconnect what you can, take them away, stop the NG feed and aspirate, so there's no episodes of vomiting or aspiration, but disconnect everything that you can safely. We then use a procedure called patient wrapping. You place 3 pillows over the patient's chest and then a clean sheet on the top, as you can see here. And then you kind of roll that up almost like it turns into a suite. The patient then has a slide sheet underneath. They're slid to the side of the bed, slowly rolled over. All this is being led by the person at the head end who's managing the airway, and then spun onto their front, where you can take things away. As soon as they've been put back, you need to reattach all monitoring, make sure that ET tube is patent, not kinked, and we recommend using CO2 monitors throughout. Reattach the ECG electrodes, reconnect all lines, and do a step back spot check that everything's in place. There are written protocols and procedures and checklists, and we, even with the experience we have now of proning so many people in the last 18 months, we still use that checklist for every single person that we prone to make sure we don't miss anything. Potential complications, the most commonly cited being pressure injury and pressure sores. We see a lot of patients with facial edema, eye swelling, eye damage, so it's important to make sure the eyes are taped shut, for example. Thinking of if they're lying on any lines, catheters, the ET tube, or even more difficult, a tracheostomy, to make sure you have some sort of soft compresses, something in the way to stop pressure damage. A real danger is ET tube blockage due to kinking or excess secretions. If you have somebody and we're going to come on to the physiotherapy aspect again in a little while. But if you have someone that's had quite a high secretion load, that change in position could loosen some secretions and easily block an airway. That's a rapid return to supination and an airway replacement. So thinking about these things and being mindful that these things could happen. We've talked about the facial edema, displacement of lines. Even with the best will in the world, these things can still happen. There's a lot of lines, a lot of attachments, a lot going on, but just making sure that you're aware of what is and managing things as safely as possible. A lot of these patients are quite unstable anyway, just in being supine, particularly those that are requiring proning. And you may see some degree of increased instability on that change of position or even cardiac arrest in the most severe cases. We've seen quite a high incidence retrospectively now of brachial plexus and shoulder injuries. A lot of these people spending a long time in the prone position, they're paralyzed, deeply sedated. The shoulder is quite a delicate joint without that protection of muscle tone. So actually to be very mindful of how you're managing your shoulders. Doesn't feel as important when you're just trying to keep somebody alive and oxygenate them, but actually down the line with some significant pain, weakness issues in people and follow-up. And also the risk to staph injury. Some of these patients can be very heavy, can be quite a difficult procedure, and just being mindful that you have the right skill mix and the right number of people around. In terms of care of the prone patient, we tend to adopt a swimmer's position. Again, there's different guidelines, there's different options, but this just involves having one of the arms elevated and changing that every 2 to 4 hours just for pressure care. The pillows that we put in before when we change that position will help to reduce some pressure on the chest, the abdomen and the knees. And the recommendation is that the whole bed is positioned into a 30-degree reverse Trendelenburg. The bed's flat, you tend to get quite significant facial edema and can cause quite a lot of significant damage. So we tilt the entire bed 30 degrees to help drain secretions more, or drain fluid more down to the feet as such. So in terms of caring for the prone patient and chest care, as I mentioned before, often these patients are quite deeply sedated and paralyzed. There's risks of secretion retention and blocked ET tubes. We recommend that nursing staff in the bed space will perform suction at least once per shift. That's even if the chest has been completely clear and non-productive. And that's to make sure that airway is clear and stays clear, and to instigate chest physiotherapy where that's indicated. Now, when we first started, and this is kind of right from the beginning of wave 1, and these are some of my own experience and observations, as I mentioned before, these people were being admitted with extremely high acuity of illness. They were probably, and probably remain, some of the sickest patients I've ever seen in my career, those people ventilated with COVID-19, often on high or maximal ventilator settings. They had a transient hypoxia, which meant even with minimal intervention, you could be listening to a chest and they'd desaturate to the mid-80s and take up to 2 hours to come back. So very unstable, very labile saturations, often needing quite high sedation requirements. And we saw a significant level of agitation and asynchrony. And not really knowing what to expect. I think a lot of the early reports from both China and Italy suggested this was going to be non-productive as a disease. Patients were coming in with quite significant ARDS, but secretions weren't an issue. The chests were dry, they wouldn't need physiotherapy. And our initial approach was actually to be quite hands-off. We didn't want to put the patient at risk. We didn't want to put staff unduly at risk. So for the first few patients that came through, they got very minimal physiotherapy. But what we often found, patients who were being proned, as they were then returned to supine, would often desaturate quite significantly. They would often become quite cardiovascularly unstable. And we had a couple of instances with really thick secretions, people blocking ET tubes that needed replacing, or needing lots and lots of suction to try and clear these thick, tenacious secretions when they've been returned into a supine position. And often due to that event and that instability, they returned back to prone, and they were starting to spend 24, 48 hours in prone because it's the only way we could keep them stable. So it started to raise the question of, do we need to be doing more as physiotherapists? But there are a number of challenges to trying to introduce that. We had restrictions around assessment. At the time, we weren't using stethoscopes, we weren't auscultating. That was due to restrictions in our PPE. Some people were wearing hoods, some people had masks, visors that meant you couldn't even wear a stethoscope. And also worries again at that time around infection control. We know ventilated patients anyway have impaired mucociliary function. I'm going to go into that in a second. These high levels of positive pressure, ventilator requirements, high levels of PEEP, the absence of any cough effort, these thick tenacious secretions on a background of poor lung compliance. And actually what we hadn't really accounted for was the obesity. And the BMI of our patients that we saw through the first 2 waves again meant that actually 88% of them were overweight and 50% were either obese or morbidly obese. So we were seeing some very big people with some very big chests to try and treat. From an assessment point of view, we relied quite heavily on our palpation skills, putting our hands on and feeling the chest. Is the bilateral air entering? Are there any palpable secretions? But also feeling the ventilator tubing to see if we could feel any secretions being transmitted through the tubing as well. And started to rely as well quite heavily on expiratory waveform analysis. So looking specifically at flows. So we've got everything above 0 is inspiration, and this is expiration below the line. What we're looking for is one of two things, either sawtoothing. So the inspiratory and expiratory flow should be quite smooth. The airways are smooth. You shouldn't really see too much turbulence. If you start to see this sawtoothing on expiration, it either suggests you've got a lot of fluid in your ventilator tubing, or actually there are some secretions causing turbulence within the airways. And it's something that's quite typical. It's quite easy to spot on a ventilator waveform. And even if you've had a feel of somebody's chest and can't feel anything through, if you're seeing this picture, it warrants further investigation. The other thing this should be is quite a nice triangular shape, and it shouldn't be too steep on the expiratory phase. So you look down here, and what's actually happening is on the bottom graph, on expiration, there's a big downward spiral that then comes up, and it becomes a lot more horizontal. And what this actually represents is a restriction to that expiratory flow. So if you've got a nice big open airway, as you breathe out, that recoil, it's a uniform line into a triangle to clear those gases. What can happen either with secretions, if you have a big plug that's narrowing the airway, it reduces the speed of expiration and it starts to look like this. That could be a sign that there's a big plug sitting somewhere in a high airway, or it could be a sign of bronchospasm with, again, that restricted expiratory flow. So we started to use these expiratory waveforms with every patient we saw as a really nice method of looking at evidence of excess secretions. Now, in terms of our normal secretion clearance, we rely very heavily on our mucociliary escalator. It collects any debris, any particles, any infected materials coming in and clears them. And we know that the mucociliary escalator clears mucus at around 10 millimeters per minute out of the chest. This was a study by Conrad quite a few years ago now, but they looked at the mucus transport velocities in patients who are mechanically ventilated. And what they found by putting radioisotope into the right and left main bronchus is once you put somebody onto a ventilator, the mucociliary escalator pretty much stopped working and the mucus didn't move at all. And certainly in those with the most significant restrictions to movement went on to develop pulmonary complications and pneumonia. So you've got the mucus that's sitting, certainly not getting any help from mucociliary escalator because of the high pressures being delivered into the airway. So we're starting to lose some of our natural body's clearance mechanisms. Now, positioning is one simple way we can start to address the balance, getting somebody positioned in a drainage position. Whilst we might not have an effective mucociliary escalator, we can start to use gravity to move secretions out of the lungs and towards the mouth. But with those patients with COVID-19, we know they're quite unpredictable. We know they're quite unstable. They're quite susceptible to desaturation, even with minor changes of position. So you can come in and think, I'm going to put somebody into sideline to drain secretions. They desaturate quite significantly to the 70s, for example, and that's ended your treatment and you've actually been able to move anything. So positioning could be, whilst very effective, sometimes actually was not possible because of the level of instability. We often found people became hypertensive or very agitated on even minimal intervention. And as I mentioned before, secretions are often very thick. So we were using saline installation, and I'll mention that a little bit later as well. But certainly once you've got somebody into a prone position, thinking about alternate sideline becomes much more difficult. What we did to manage this, well, actually, we moved people from the 30 degrees to flat or even a slight head down position during physiotherapy treatment to try and add in some degree of drainage. And we had some effectiveness with that, particularly if we use saline in conjunction. So we would instill saline in the 30-degree reverse Trendelenburg and then flatten the bed or put them head down with some manual techniques, which I'll come on to, and that helped to start to access some of these thick tenacious secretions. And we also found some benefit from treating them when they were stable in prone prior to resupination, because it helped to clear secretions, it helped to manage that transition of prone to supine, but also meant you were dealing with a more stable patient. Now, to understand the next stage, we need to think about something called two-way gas-liquid flow. And I'm going to keep this just nice and simple, but what it's suggesting is if we've got sputum in an airway, Movement of that sputum is dependent on any airflow that's going across. And it's the balance between the air that's coming from the mouth, from the ventilator, being driven into the airway, and then the elastic recoil of the lungs and the weight of the chest that then causes the expiration. So if these things are equal, that sputum may wiggle, but it's not going to move at all. The problem we have with patients who are ventilated with COVID-19 is we have high inspiratory pressures, high levels of PEEP, and high ventilatory pressures in total, driving down the airway to try and maximize oxygenation. In terms of recoil, we've now got very stiff, very wet lungs. We've got poor respiratory lung compliance. We've therefore got limited elastic recoil. And then on a background, patients who have either a very weak or ineffective or absent cough effort. So we've got really high pressures coming into the lungs, but reduced pressures coming out. And what this will actually serve to do is either prevent any sputum from moving or mean it gets further embedded into the chest. Manual techniques, vibrations, shaking is probably the mainstay of treatment we use almost with every single COVID-19 patient that we had. The idea being we commence a manual technique on the chest through chest shaking at the end of inspiration and shake through expiration. So we start to try and redress some of this balance. The ventilator delivers the breath in, and then we will shake that air back out to get a much greater expiratory flow. And we know from bench studies that if we can increase peak expiratory flow, so expiratory flow rates are 10% higher than inspiratory flow rates, we will start to move secretions higher and out in towards the mouth. For patients who are paralyzed, the other thing we need to consider is when we go down to suction, there's absolutely no cough effort. So if we're just suctioning a patient who's paralyzed, all we're doing is cleaning the ET tube. So what we started to add in as well was an assisted cough. And that was either achieved through a ribcage compression right at the point of suctioning, or an abdominal thrust like we would with somebody who's had a spinal injury, for example, again to try and combine an assisted cough with a suction to clear as much secretions as we could. Combine that with positioning where possible, and now we've got gravity assisted drainage with big thrusts of expiratory flow, and we were able to access quite significant amounts of secretions and get really good success with clearing these people's chests. This is just to back that up really. So this is some work by Danny Marty a few years ago now. This is looking at the effect on mucociliary clearance of people of ventilated, these are actually ventilated pigs. What you can see, no manual respiratory compression, just a pig who was ventilated. This is the mucus clearance rate, 0 meaning everything stays where it is. So just by being on a ventilator, the mucus was gradually moving 0.5 millimeter into the airway every minute. So it's embedding secretions further into the chest without any intervention. If you perform a soft respiratory compression or a soft shake of the chest, it stabilizes a little, but it certainly isn't coming out. But if you do a hard compression, an assisted cough, a manual technique, you start to move secretions away from or further up the airway where there can be access for suction. So manual technique, shaking, hopefully in combination with positioning, is a really effective method of clearing these secretions from somebody's chest. I mentioned before that they were extremely thick and tenacious. We weren't using heated humidification. We were worried about contamination across the unit. What we did very early on was start to prescribe every patient on admission on carbocisteine to try and add in a mucolytic to loosen secretions. But we also were using quite liberal saline before manual techniques to shake that around, try and loosen secretions off the chest, followed by an assisted cough with suction. And we got some really good results with that. In terms of other techniques that physiotherapists might use, manual hyperinflation is one, to try and put bigger volumes of air into the chest that then can be shaken out to again increase that expiratory flow. We avoided MHI completely. There's a high risk of further lung damage, further inflammation, significant risk of contamination for staff and other people. When we did use it in an emergency that somebody was desaturating, we had to try and use it as a rescue therapy in effect. We would clamp the ET tube before we disconnected the ventilator and attach the bag. So just try and maximize safety. But in terms of physiotherapy treatment, we didn't use it at all. We can use the ventilator to try and increase inspiratory lung volumes, to get more air, to get behind secretions and to increase peak expiratory flows. Often patients were on already maximal peak pressures that meant there was no capacity. But if you did have somebody that had a little bit of reserve, again, that could be quite a useful way of moving secretions. So to summarize the respiratory treatment, often it requires 2 people. Factor that into any staff planning. You might have one person who's shaking a chest and doing assisted coughs whilst the other is performing suction. Positioning can be very effective. but you need to consider both respiratory and cardiovascular stability. And certainly those prioritization to one side or the other is quite difficult in prone. Manual techniques are essential and extremely effective if timed appropriately, but adding that assisted cough. Saline is a very useful tool. I know it's been contentious in the past, but I don't think we would have cleared half the chest we did without liberal use of saline. Avoid MHI, use VHI, but consider those maximal pressures. And I think the biggest thing I've learned as well in the last 18 months is desaturation is very common. There were days where every single patient I walked away from after treatment was worse than when I started, but an hour later they were a lot better. So patients didn't tolerate treatment particularly well, but they did recover, and they recovered to a better position. And it was almost becoming a bit more confident that clearing the secretions would result in an improvement over the course of the treatment. So just to conclude, prone positioning is widely used in severe cases of COVID-19. We're still using it now. It's still extremely effective. It can result in significant improvements in gas exchange and oxygenation. It requires a skilled team and excellent communication. If you don't have checklists, get checklists. It's just a really nice way of making sure everyone's going through those stages. Complications are common, but can be prevented with care and attention to detail. Respiratory physiotherapy is challenging, but it's absolutely essential due to the thick and tenacious secretions we're seeing in these patients. Thank you very much for listening. I hope that's useful. I will answer some questions as asked, but my contact details are also on here. So if anybody wanted to get in touch directly or had any thoughts or comments or more detailed questions, by all means, feel free to contact me. Thank you very much for listening.
Thank you, David, for that very informative presentation on acute management of physiotherapy management of COVID patient. Thank you indeed. Then shall we move on to our next speaker? We'll have the question and answer session at the end of the Samantha's lecture, if that is all right with you.
Absolutely.
Okay. We have already got few questions. Okay. Our second speaker is Ms. Samantha Cook. She's highly specialist physiotherapist in critical care at Barts Health NHS Trust. She obtained her bachelor's degree with a distinction in physiotherapy, and she has MSc from Brunel University in London. She did her NIHR and HEE internship at City University Hospitals. She is currently working as a team leader in cardiothoracic critical care at Barts Health NHS Trust. She is currently engaged in investigating functional outcome of COVID-19 patients receiving ECMO. And she has more publications as well to her name. I invite Ms. Samantha to present her presentation on acute rehabilitation in COVID patients. Over to Samantha.
Lovely, thank you very much. Sorry, I realised I started sharing my screen and then couldn't unmute myself. Bear with me just a moment.
We can hear and we can see perfectly.
Perfect, great. Okay. Yeah, so I'm Samantha. Thank you very much for the invitation to come and talk on this in this webinar. And yeah, just a little bit more background for me. So during the first wave, I was at St Bartholomew's Hospital, which is one of the main, one of the cardiothoracic sites for Barts Health during the pandemic, and we expanded our beds as a extracorporeal membrane oxygenation surge centre. So we took a lot more of the ECMO patients during that time. And then during the second wave, I was redeployed to our main Royal London Hospital site, which was the main London surge centre for COVID-19 beds in ITU. So I have the pleasure of talking to you today about acute rehabilitation in COVID-19. And the way that I have structured this is I'm going to talk a little bit about just some of the components of rehabilitation. And then I think what's really key is to talk about the challenges of acute rehabilitation in COVID-19 and how that differs from our normal rehabilitation in ITU. And then what I thought might be quite helpful is going through like a case study for acute rehab, which then covers the risk assessments and the thought processes behind our decision-making for rehab and ITU. So components of rehabilitation. So rehabilitation refers to the return of an individual's function. So multi-components, some of these include what I have on the screen here. So pain and sedation management, which includes sort of daily sedation holds, keeping your sedation lighter, which has better outcomes for patients' recovery, early mobilization, again, something that we're going to talk about during this session, speech and swallow, also including your eating and drinking. So real big importance of allowing patients to be able to communicate as early as possible, and obviously fuel for recovery. Functional rehab, so we have occupational therapists in critical care here in the UK. We didn't have them during the second wave of the pandemic where I was redeployed. Things like spiritual care, environment, family, normalizing routines, so day and night cycles, and psychology and delirium management, a really big part of component of rehabilitation. So this is what we focus on normally and what we consider when we think about rehabilitation of the patient in critical care. So what guidance that we can use. So the Society of Critical Care Medicine very kindly put out some guidance for prevention and management of pain, agitation, immobility, sleep in the ICU. And what they came up was the A to F bundle, which was a bundle to promote liberation from ICU. So the bundle includes sort of assessment, prevention and management, as you can see from A, for pain, spontaneous and awakening and breathing trials, so lightening the sedation on a daily basis, considering your choice of analgesia and sedation levels, delirium, so early recognition of delirium, how we can assess for that, prevent and how we can manage it, early mobility and exercise, and then think about empowering the patient and family engagement. So this again is what we would do normally. So what are the challenges for a COVID, I've realised that says COVID-10, apologies, I'm supposed to say COVID-19, rehabilitation? Well, the main thing, staffing levels. So a lot of places, took on extra beds as surge centres, and we were still running at our normal staffing levels. And then also we had a reduction in staffing levels. And that included everybody for personal isolation reasons, contact isolation reasons. So nursing staff, consultants, therapists, healthcare assistants, everybody that's so vital to supporting care in ITU and that recovery. Working in PPE is a huge challenge in itself. So even just communication with the normal sort of masks that we're wearing, or visors, or people that would wear the full suits or the reusable mask, being able to actually communicate with each other was a real challenge. And then also if you think about the patient who we've then woken up in ITU, probably doesn't have much memory or recollection of what's happened, and they're waking up and all they can see is our eyes, when, we very much, there's a huge value in being able to see facial expressions for reassurance and feeling safe in the ITU. Pharmacy and medications. So there was a period of time when there was reduced resources available for certain sedatives and medications. This then impacted on our sedation practices. The environment itself, so again, with surge areas or people that have expanded their ITU and fit more beds into the same space available, is a challenge when we're thinking about rehabilitation. Even access to equipment for things like chairs. I've put walls there because we use a lot of charts to try and help orientate people, and the expansion at the Royal London Hospital didn't have any walls, and it was just like a standard Nightingale open bay. So being able to orientate people, or even bring in sort of pictures and things that could be familiar for them, was also a challenge. And I've touched on this a little bit already, the acuity of the patients. And as David mentioned, some of the sickest patients that we have ever seen, and also just the volume and number of those patients. And again, still working with your same staffing levels or reduced staffing levels, meant that there was a change in priorities. So referring back to the bundle, which the Society of Critical Care Medicine put together, focusing on sort of delirium and mobility, actually, unfortunately, became a lower priority, with this being a novel virus, and actually just being able to try and manage the patients and keep them alive became the utmost priority at this time. And no visiting, so family reassurance plays such a huge part in the recovery. So these, I feel, were some of the main challenges that we faced, trying to do our things that we would do normally for rehab and ITU. So what I'm going to talk through now is a case study, and looking at rehabilitation of the of a COVID patient in ITU. So thinking about when is the right time, how do we assess whether this patient is appropriate, what do we need to know before we can start, how will we do it? So safety being the utmost important. Do we have the correct staffing members to do it, to include skill mix, nursing staff as well? What does our environment look like? What equipment is available? The actual intervention itself, so clinical reasoning as to why we're choosing to do this intervention now. What do we need to adapt? What do we need to monitor? And then how we will progress that intervention. And then the next steps from there. So thinking about your step down, your discharge pathways. So the initial part, so think about when is it the right time? How do we know if our patient is appropriate? And this comes down to our multi-systems assessment. So we used an A to E assessment, but we've also used a systems assessment looking at sort of like CNS, CVS, respiratory, as long as there is a comprehensive assessment which covers aspects which can inform your clinical decision making. The format of it doesn't really matter. So this is our patient. So A is airway. So our patient has a tracheostomy. They're on pressure support ventilation, 22/8 with a respiratory rate of 28. Saturations are 95. They're on 50% oxygen and their CO2 6.5 with an O2 of 9.5. So when we're thinking about this, our patient is already on quite a considerable amount of oxygen. It's just how we modify that. We go. Cardiovascularly, so heart rate, blood pressure, relatively stable, temperature-wise, okay. Note here is they're on elevated pressure. It's amount, and again, not necessarily contraindicated, but something that we need to consider. Is there a nurse present that's going to be able to help manage us with this? Perhaps if it needs to be increased during the treatment time. D for disability, so our patient is alert. So we use the Glasgow Coma Scale of E4VT-M6. So our patient is following commands. However, we're unable to do a CAM-ICU assessment. So our CAM-ICU is our confusion assessment method. And it's a tool that we use to be able to assess whether our patients are acutely delirious. And a lot of the time we couldn't do these assessments because our patients were so globally weak that they weren't able to follow some of the instructions, which were hand squeezing. And then E, so thinking about your connections that you've got and your environment. So a patient has a catheter, a bowel management system, your standard connections for monitoring, so Artline, CVC, they're still connected to the ventilator, they've got an NG tube and some infusions. So we've done our kind of end of the bed assessment. On the surface, okay, looks like we could proceed forward. What we need to know now is how our patient responds in the bed before we move on to the next step. So we might want to think about doing an on-the-bed assessment, and this could be range of movement exercises, active assisted, if your patient can engage. It would be good to know if the patient has been rolled. Again, you might come onto shift where staffing has been so short that actually a patient hasn't been rolled in this time, so the nursing staff isn't able to give you that information. That could be something that you choose to do there and then at the bedside, or sitting the patient up in bed. Has the patient actually sat up yet? If they're lying quite flat in the bed and we go from sitting, lying to sitting, actually those physiological changes that occur, we need to know if the patient is going to be able to, is stable enough to be able to sit up on the edge of the bed. And this, we're going to have a discussion with nursing staff what ability is and any history that they can tell us during that time, if possible. And I've put down there, so for us, if you are unsure, to always discuss with a senior physiotherapist if you have access to somebody. Again, safety is the most important factor here. So I've included this expert consensus and recommendations, which was put together by Carol Hodgson and colleagues. And again, this is just a really nice document that gives a general sort of overview of a traffic light system for risks in each section. So these are just some examples of what's included in there. So the traffic light systems reflected that green, very minimal likelihood of adverse events or low risk. The yellow triangle, there could be a risk of adverse events, so to proceed with caution, and then your red is kind of like a bit of a hard stop. And they've kind of separated it down into sort of in-bed exercises and out-of-bed exercises. So this can be just quite a useful tool to guide your decision making. So we've talked about when is the right time. Yes, we think our patient is appropriate from our on-the-bed assessment. Now we need to think about how we will do it. So this is when your risk assessment comes in, hard assessment load and environment, and there can also be an O for other. So I've had a with other patients. We've got 3 physiotherapists that are available, but we need to think about the skill mix. So we had a mix of ICU therapists and redeployed staff. So some staff that only work in outpatients and don't have much experience of working in ITU. If you've got 3 from that background, it's probably appropriate to attempt to complete rehabilitation. Load, so our patient is a severely weak patient. They do have a normal BMI, but they do have a tracheostomy and they are on some vasopressor support. So again, we need to be mindful that somebody needs to be able to look after the airway, and we need to have access to somebody who can help support us should they need it, as our patient is on noradrenaline. The environment, so again, this is thinking about your floor space next to the bed. Is there actually enough space that we can sit our patient there? Lines and attachments, what can we disconnect potentially moving forward that could make this a bit easier? Do we have access to slide sheets? And can we maintain things like privacy and dignity as well? And again, so we're going to communicate with the nursing staff about what we plan to do, what if they are happy, and proceed from there. Yeah, so a plan, just to reiterate, a plan before you kind of get to the bed space after you've done your initial assessment is really key. So logistics, we want to aim to go closest to the ventilator. So we've got enough slack on the ventilator tubing. This is just an example of the 3 therapists that could be present. So we've got Susie, who's a senior ICU physiotherapist, and she's happy to look after the trachea. We've got John, who is a redeployed band 6 musculoskeletal physio. He is happy to climb on the bed behind the patient to support the trunk and maintain head control. And I'm involved and I'm happy to be in front of the patient. Fran is our nurse and she's going to be with the patient with the next bed. She is happy that we have a plan and we're moving forward. And she's also happy to pause the feed, disconnect the NG tube and disconnect the insulin to reduce some of the attachments at this time. We're happy with our environment and that we know where the emergency alarm is located, and we have slide sheets ready should we need to make a quick exit from sitting on the edge of the bed back up into the bed. Great, so we've talked about, is our patient appropriate and how will we do it? Now the actual intervention itself. So we're aiming for fully informed consent by explaining to the patient the reasons for what we're doing and why we're choosing to do this. And if any issues arise, we will stop and ensure the patient is safe at all times. The actual intervention itself is individualized, and this comes from your assessment whilst on the bed. So as mentioned previously, a lot of our patients were densely weak. So having a plan, thinking about if upper limb or lower limb movements, we're probably not going to get them up and start running around the ICU. We're just going to go for those initial steps where they're going to need a lot of support to sit on the edge of the bed to start with. We need to be mindful, and David also mentioned this, that these patients have transient hypoxia and they rapidly drop their saturation. So we need to be prepared that we are happy if we need to increase oxygen delivery or change ventilator settings, that we are also capable to do that at the time. So if we do get a drop in saturations or respiratory rate increases, again, these patients are highly fatigable. And don't forget, this is the first time that the patient is sat on the edge of the bed. So we're going to give the time to recover. It's going to be slow. What you might want to ensure is that John, who's behind the patient, can fully support the patient so they can sit backwards, increase the oxygen if you need to, increase pressure support if your patient is feeling that they're gasping for air and you're competent at ventilator settings. So this is what we actually achieved. So our patients sat for 4 minutes. They didn't have any independent sitting balance as expected because they are globally weak. We did some gentle passive range of movement just while sitting on the edge of the bed. And we found that our patient did fatigue quickly. And this is quite a general pattern from my experience on that initial sort of waking from the sedation and that first sit on the edge of the bed. So we have done our intervention, we have adapted it, and we continue to monitor as we go through. Now we think about how we will progress. So thinking about time intervention, again, it's all individualized for your patient and your daily assessments that will be reflective of your clinical decision making. But these dense patients, from my experience, they take a little while to recover. So you might consider alternating things, ventilation and days. Reviewing the patients, we are the most consistent people in the ICU, if that makes sense, if you're in one static area. So we actually get a good understanding of how the patient is over the previous days. So if we find that perhaps we sat our patient on the edge of the bed yesterday and today they seem even more fatigued, perhaps they've got increased oxygen requirements, needing more ventilator support, and they're very tired, then actually we might want to consider, okay, should the patient have a rest day today, and we consider perhaps hoisting to the chair the next day or continuing rehab so that we space it out. I think as therapists, we are very keen to do as much as we can, but let's not forget that rest and sleep and recovery all contribute towards that positive recovery trajectory. Other things we might want to consider is increasing of ventilator settings, as I mentioned previously. So to have somebody with you who is competent with using the ventilator, and that could be during your intervention or actually even overnight to give your patient a full rest. And starting to introduce other components of rehabilitation, so speech and swallow assessments. And again, it will be thinking about kind of alternating your days with this potentially, but it is always an individualized approach. So this is what we measured our patient for: a tilt and space chair and a hoist sling. We considered a hoist to the next, hoist into the chair for the next day if staffing capacity allows. And again, it's your same risk assessment of your task, individual load and environment. Do we have the staffing capacity to hoist the patient out? We also found that we were hoisting patients back as well, again, because the nursing staff were being so stretched. So it is a communication and a plan with the whole of the MDT. Want to think about assessing for appropriateness for weaning from ventilation. And again, if you're conducting your rehab at the same time, we would like both to improve on a positive trajectory at the same time. So that might mean alternate days of wean and rehab. During our first wave, we didn't do any cuff down speaking valve trials whilst patients were on the ventilator, and we weaned them from the ventilator first onto trachea, and then put them on the speaking valve. During the second wave, we agreed to take a calculated risk, and this was part of the whole MDT decision, that we would encourage people to have their speaking valves in line with whilst on the ventilator. But again, I think that is site specific and an agreement within the whole MDT. And what we did continue in terms of rehab was sitting on the edge of the bed to improve sitting balance. And as I mentioned previously, more is not always better. These patients do need the time to recover. Moving on to thinking about progressing the rehabilitation to our A to F bundle, so orientation charts. So again, this was difficult because we didn't have any wall space, but we did use the like the screens, which we could actually attach sort of magic chart to the paper that we could write on to orient to time and day where they were and who their nurse was. Delirium was a big issue in this cohort of patients. Natural light, encourage good teams, minimizing noise in the ICU, and then moving on to goal setting. So we try to encourage the patient as much as possible and empower the patient to set their own goals. Sometimes that's not possible, but we try as much as we can using outcome measures. And we were very fortunate that even though we didn't have visitors into the hospital, we had an inquiry hub where we could make calls with the family. And again, that was predominantly reliant on therapists to make that connection, to book appropriate time for the patients, perhaps when they were sitting out in the chair, to then be able to arrange these calls with family. Thinking about a stepwise progression in terms of your rehabilitation. And so achieving your sitting balance first, challenging outside of that base of support, more functional rehab. So things like your hair brushing, your teeth brushing, your normal day-to-day routine activities that you would do. And then once sitting balance was achieved, we moved on to, we have some equipment called the Arjo standing hoist, which is an electric standing hoist. And again, it's still risk assessment based on the space and the equipment available and the staffing to be able to do it. Stepping without the foot plate and other less supportive equipment. So that kind of stepwise progression. Okay, so then we think about what are the next steps. So idea the new and had a lot of ongoing complex needs. Two very prominent symptoms were fatigue and breathlessness. So once our patients stepped down to the ward, the focus was mainly targeting large muscle groups, sort of breathlessness management, fatigue management, pacing of activities, and again, trying to ensure sort of sleep and day and night routine were all optimized. A lot of them still had high oxygen requirements as well. So we were the lead on reviewing this on a daily basis and trying to see if it's as appropriate or continue with oxygen as required. As David mentioned, some central peripheral nerve injuries from proning or sustained bed rest positions. So again, we are usually the people that would pick up on this from our full neuro assessment. So as soon as our patient is appropriate to complete a neuro assessment and they have recovered from that initial sort of dense global weakness, that would help to contribute towards sort of clinical reasoning and rehab recovery pathways. And then thinking about your progressive strength and endurance exercises and your discharge planning. So to summarize, rehabilitation is multifactorial. We try to work towards what we would do normally in ITU. So thinking about all of those components of rehabilitation, which we know can promote a positive recovery for patients. Your risk assessment is really essential and safety remains the utmost priority. And it's not a sprint. If you don't have the appropriate staff to complete your rehabilitation, sit on the edge of the bed, hoist to the chair, then we reassess for a different time. Communication is key. And I honestly think that that's one of the biggest messages to come out of this, rather than, I think at times we can work very siloed and in our own kind of areas. Actually, what working during the pandemic in PPE has done is we just need to break down all of these barriers and make sure that everybody is on the same page as much as possible, including the patient and their family and their relatives. Our comprehensive assessment will identify early complications and again, will help to contribute towards decision making for that pathway of recovery. It's an individualized plan. So even though I gave an example of our patient who was densely weak, we've also have patients who are densely weak who then actually recover very quickly, and some that continue to take a long time. So it is slow recovery, and you want to be thinking about pacing your rehabilitation, considering your alternate wean and rehab days, and remember that more is not always better. So there's just a couple of resources there that I wanted to share if people are interested, with some links as well. Okay, thank you very much.
Thank you, Samantha, for that very informative and lecture on rehab. And it's a very good eye-opener for our part of the world to how to rehab a patient post-ICU care or during the recovery phase of the ICU. Okay, David is also here. So can we go to the question session straight away? Okay, we got a question for David, I suppose this one. How you can give physiotherapy for a patient who is intubated, probably with a minor air leaks in with the tube, I suppose.
Air leaks in terms of pneumothoraces, or
probably pneumothoraces or kind of air leaks. Do you give physiotherapy for patients with pneumothorax? I mean, in COVID patients, we have seen some incidences that they get pneumothorax and pneumomediastinum kind of situation. So what is your experience in regards to that? Do you give physiotherapy for those kind of patients?
Yeah, to be honest, it wouldn't hugely change the input because we were non-reliant on positive pressure. I think if we were considering things like ventilator hyperinflation and manual hyperinflation, they would be avoided or used as a very last resort if there was a drain in place. In terms of manual techniques, positioning, saline, we would do exactly the same things as we had been before. I think sometimes if there's significant surgical emphysema, that can make assessment more difficult, but actually it wouldn't particularly change our management.
So in that, otherwise, even if they have a pneumothorax, you go ahead and give the physiotherapy on them, is it?
Yeah, I mean, if you think about the nature of what we would be doing, so we're compressing the chest to increase peak expiratory flow, and then by nature of when we finish and let go, that will trigger a negative inspiration. So we're not putting any high positive pressure into the chest. Clearing of secretions will actually ideally help to reduce ventilator settings, which will help with resolution. So yeah, like I say, other than avoiding the use of positive pressure or increased positive pressure, such as ventilator hyperinflation, then it wouldn't change my management particularly.
Okay. There's another question. How often do you give physiotherapy in COVID patients who are on ventilator? The frequency.
Yeah, I think this is about being targeted and looking at your resources. So there are a group of patients who are ventilated with high levels of support and non-productive chests, and a kind of cursory screen to say, there's nothing coming up on suction, there's been nothing coming up for the past few days, we don't need to get involved, and we would be much better to go and see the really productive chests, and then that can be 4, 5, 6 times a day, depending on how productive they are and how things work out. So I'd have a targeted approach, but it's got to be I think everyone deserves at least a screen every day. I think if they're productive, we would see them at least once a day, but certainly for groups who are productive, we would see them on multiple occasions.
Okay, thanks. There's another question. When we are giving physiotherapy, what is the place of regular nebulization with saline? Nebulization with saline to loosen the secretions? Do you practice?
Yeah, I know feelings around nebulized saline is controversial. We, in areas in some of the hospitals I've worked in, they don't use any heated humidification, so we do use saline nebulization. I think with COVID, one of the challenges is you need to have a limb that means no circuit disconnection. I think then it can be used very effectively. And certainly if it's just something that adds anything into your arsenal to try and loosen secretions, then I think it can be of use. But it's making sure you're not disconnecting the circuits as such.
Do you use N-acetylcysteine nebulization as well to loosen the secretions?
Not routinely. There were discussions around whether that could be a useful method. Our tack generally was carbocysteine, saline nebulization where appropriate, and saline installation. I think it'd be an interesting study to see the effectiveness, to be honest, but it wasn't routinely used.
Okay, we usually use it. That's why I asked. Okay.
Yeah.
In regards, okay, Samantha, go on.
No, sorry, I was just going to say that we don't routinely use it in this trust, but I have worked at a trust where we would give, not obviously, it wasn't in a COVID cohort, but that would give NAC nebs for like really thick secretions, but it's only one place that I've worked at before that I've done that.
Okay, good. One more in regards to proning, do you prone tracheostomy patients as well, or what are the problems you face when you have a patient is having a tracheostomy and you need to prone them?
Yeah, I think it's certainly easier with somebody who's got an ET tube, particularly when, as I described, we had quite a obese cohort with very big necks. But it was still done. It was still done safely. I think it was making sure that you can actually still visualize the tracheostomy. It certainly felt higher risk of potential loss of airway or decannulation, but we didn't have any incidents. And 70% of our patients had tracheostomy by the end, but this tended to be more once they'd come out of the proning phase. So we had a couple that were proned, no incidents, but generally it was the trachea was performed later on.
Do you do suctioning after proning in tracheostomized patients as well? I mean, okay.
Yeah, so everything would be exactly the same.
It's the same.
Just again, a close eye on the airway.
Yeah, might be difficult in compared to the ET tube. Okay.
I think that's the importance of having the slight quarter turn with the pillow in the swimmer's position. You can actually then get to the tracheostomy and see the airway. when we've had a couple of patients, as I said, who were quite large with big necks, it almost all felt a little bit unsafe when they were in that position, but thankfully it was quite rare.
Okay. I mean, this is applies to both of you. Do you have any experience? Are you doing any respiratory physiotherapy outside the ITU in COVID patients? I mean, do you regularly do? How often do you do outside ITU, say HDU or a ward setup in COVID patients?
You want to go first, Sam?
Yes, we had a step down ward, which was a respiratory ward, and we have our normal respiratory wards anyway. For COVID, we have a specific the same respiratory assessment and treatment of patients on wards and HDU.
We I don't leave ITU. I get a little bit scared and a little bit lost if I ever do. But we did have quite a lot of patients coming in the subsequent waves with high flow nasal oxygenation, CPAP, NIV, which we didn't have the first time round. We tended to find they had quite limited reserves. They would often sit on quite high levels of oxygen, static for a week or so. We did try some rehabilitation, and it seemed a good surrogate marker that if they couldn't tolerate sitting on the edge of the bed or any activity, they were the people that tended to need intubation. Whereas those that we could maintain some sitting out of bed every day, maybe some awake proning, which was very useful with certain groups of patients, would kind of filter them between those that might get better without intubation and those that wouldn't.
Any additional, I mean, this is what we discussed earlier when we planned this, any additional equipment you use to enhance coughing on these intubated or non-intubated patients during your respiratory physiotherapy?
So whilst patients were intubated, from our perspective, it was a very hands-on approach. I think some units will use mechanical insufflation, extubation, cough assist devices, via ET tubes or tracheostomies. We tended to avoid that again through the fear and risks about aerosol generating and contamination. It was used to some extent with some patients prior to intubation, those on non-invasive ventilation or heading in that direction. But generally, I'd say the majority of patients were treated with manual techniques, assisted cough, saline positioning, suction.
Yeah, ours was the same. We, again, avoiding it, but they were used on the respiratory wards, I believe.
Okay, thanks. I think probably this is for Samantha. What are the breathing exercises used for spontaneous breathing patients to increase alveolar ventilation? Do you teach any special exercises, breathing exercises, patients who are recovering from COVID pneumonia?
Yeah, I think it probably wouldn't be my first port of call. So I think if the patient could get up and mobilise, that would probably be my first port of call. But I guess there are some occasions where, you know, patients aren't mobilising, and we can go through like active cycle breathing technique. But again, I would always encourage mobilising and education around sort of breathlessness management whilst mobilising or pacing activities as a first port of call, if I'm honest, if the patient can get up.
Do you use incentive spirometry as a device to encourage expansion of your lungs? No?
We don't. I think the only cohort which does still use it at the moment is thoracic surgery, and again it's with very limited / no evidence. But I think they do. With some patients, it works quite well just to have something visual to do the breathing exercises with. But we don't routinely use it now.
Okay, thanks.
I think there's a real push towards kind of mobilisation. So we know that going from lying to standing will increase functional residual capacity by a litre, and actually sitting somebody out will recruit lung and maintain recruitment, where you compare sitting in a chair to something like intermittent positive pressure breathing, where the benefits last about 2 hours. Sitting out in a chair can last for a lot longer. So I think mobility and mobilisation is the predominant management for deep breathing, just in a more natural way.
Okay. There's another question. I will read this question. Can we do deep breathing exercises in non-ventilated patients? I don't know what does it mean. can we do deep breathing exercises in non-ventilated patients?
Yeah, I mean, I think it's probably similar to the previous question in that the first protocol, trying to get them up to mobilize them. There's no reason why you can't ask the patient to take deep breaths, but in terms of a better response, mobility would always be the first option.
Okay. Do you continue the saline nebulization after, during the rehabilitation phase as well, or just during the intubated patients only? Saline nebulization?
Well, I don't think we do routinely, to be honest. There are, with some just non-COVID patients would post-op, like cardiac surgery patients. Sometimes if they're struggling to clear their secretions, we can give them a couple of nebs. Yeah, but with COVID, I'm not so sure. I don't think we did routinely.
Okay. There's another question. This is also related to rehab. After discharging from ICU, do you continue to do rehabilitation on COVID patients, post-COVID patients?
Yeah, and again, because a lot of our patients step down earlier than normal, so we would measure it with our CPAC scores for using outcome measures, and we found that our patients were scoring considerably lower than what our normal patients that stepped down from ITU were. So they still had quite a lot of ongoing needs, in particular. Still high oxygen requirements, fatigue and breathlessness still continue to be quite prominent symptoms. So they would usually, for us, step down to a respiratory ward and continue to have ongoing input from there. Yeah, and in terms of the type of rehabilitation, again, it's independent assessment depending on what the signs and symptoms were, but a lot of it did revolve around sort of breathlessness management, fatigue management, return to normal function, functional rehabilitation for like normal daily routines.
Okay, great. And there's another question. What are the physiotherapy interventions that we can use with a patient with CPAP? This is must be on face mask CPAP.
Do you want to go, David?
Yeah, I think it's what we were mentioning before. So actually mobility is an important aspect of recruiting, keeping the lungs open. It's also one of the best ways to clear secretions. I think we would use certain breathing exercise with manual techniques if someone was productive. What I tended to find, in total honesty, was that patients who were requiring CPAP and NIV were not particularly productive and didn't become productive throughout the entire time they were on. I don't know if that was the nature of patients, and those with high secretion lows deteriorated more and ended up intubated, but it was more a case of managing breathlessness, maintaining mobility and strength and pacing rather than secretion clearance for that patient group. I don't know if that's what you found, Sam.
Yeah.
In summary, what you suggest is that it is not necessary to have a kind of a physiotherapy, that much intensified physiotherapy during CPAP mask CPAP.
It did feel quite limited at times. I think we had patients where you didn't feel like they were getting out of bed because they had their muscle strength. They were non-productive with their cough. They were breathless, and they were relatively static like that for a while. And then after a certain amount of time, they declared themselves one way or the other. So we put them on our lowest priority group.
Okay. And so there's another question like this. You have managed a lot of patients with COVID, and you interact with them quite frequently. And in your opinion, what was the best option? Is it the CPAP or the high flow they tolerate better? The patients' wise, I mean, what are their opinion, kind of in your experience?
Yeah, I think high flows tolerated better. I think the recovery paper that's just been published, which I've not read the full details of, suggests that CPAP was better for outcome, but it's very patient specific. I think depends on where you work and how things went. I feel the first wave in my trust, we intubated everybody and didn't use NIV at all. I think in the second wave, we probably overused CPAP, and I think it served to delay intubation in a certain group who then didn't do very well. And I think now we're perhaps managing patients with CPAP and non-invasive ventilation, and knowing that if after a couple of days they're not improving, they can't tolerate any rehabilitation, it's a signpost that they need intubating. So I think we're learning as we go through. But in some patients who come have a mild severe case, if that's even a thing, they tolerate high flow, they stay for a couple of days, they go back to the ward and it works very, very well. A lot of answers there, sorry.
Yeah, I'd say ours is very much the same. Early intubation on the first wave, again, to avoid anything like aerosol generating or disconnection from, and then the second wave, absolutely, there was that cohort that probably either stayed on CPAP too long or should have been intubated earlier.
Okay. Okay, there's another patient just came in. Okay. In your opinion, they ask, somebody ask, can we have the rough idea about the percentage of patients who recovered after intubation in your particular ICU?
You have to look at the IGNAC case, I think.
I think
And
my,
rough
I don't
percentage.
know, but David, fire away.
You said,
Yes.
your first wave you intubated early, and the second wave you said you used a lot of invasive methods.
within our trust, it was about 60 to 70% who survived critical illness. Around half of them went home without needing any structured rehabilitation follow-up, but 50% went home with ongoing disability that needed ongoing community input. But yeah, 60 to 70% survival, I believe. And I think that mirrors relatively with the IGNAC once you look at the ventilated population. Okay.
Was there a difference in between early intubation and late intubation? Was there, first wave and the second wave?
We actually had differences, which are quite interesting. So during wave one, we had lots of redeployed staff, lots of cancelled surgery, which meant we were able to go to a 8 till 8, 7-day-a-week physiotherapy service. During wave two, everything stayed open. So we continued with a Monday to Friday physiotherapy service reduced at weekends. And our mobility outcomes got a lot worse. Patients spent longer on a ventilator, longer in ICU, slower to move, and more needed rehab at the end. So I'm not sure. It feels like the mortality of those that weren't intubated were higher, because I think, as Sam said, we had people that spent a week or two on CPAP that then died, and we're not sure whether they would have died anyway or we should have intubated them earlier. But from an overall ventilation outcome, I think we had other differences that had more of an impact.
Okay, I think that's all we have for the moment. I would really like to thank you both for your wonderful presentations and enlighten us on your acute management of physiotherapy and then the rehab, which I think we need to improve a lot more on our ICU patients. So we hope to, continue and get your support for especially the rehabilitation part. We need to improve our rehabilitation, of course, with COVID and non-COVID patients who are coming through our ICUs and going out. And I think I can see a lot of responses. You may also be able to see it was a wonderful session I think we had. Thank you, David, and thank you, Sam, for both of you. I think we had a lot of conversation regarding scheduling this thing, but somehow we managed to do it. Thank you very much for both to spending time with us and enlightening us. Okay.
Thank you so much for the invitation.
Thank you very much.
Yeah, thank you.
Thank you. Bye-bye.
Thanks a lot.